Good morning, everybody. Thank you for hopping in and joining us this morning. We have a really exciting Grand Rounds presentation that we're looking forward to hearing from. I imagine everybody is. Before we do that, we have our weekly updates, and we have some special updates this week. We have our three chief residents, Dr. Hoppenfield, Moore, and Castillo, who are going to present some clinical decision awards they give out annually to our residents. I'll turn it over directly to you guys.
Hi, everybody. Good morning, and thank you for letting us be here this morning to help honor our residents. So this morning, we, the medicine chief residents, are very excited to announce the winners of our internal medicine residency's annual clinical decision-making awards. Every year, we recognize a select number of residents for outstanding displays of clinical skills and judgment, either in wards or in clinic. We solicit nominations from both residents and faculty throughout the Department of Medicine, and we were thrilled this year to have many outstanding nominations, as we do most years. I'm thrilled to announce our first winner, who is Tim Ellis-Caleo. As the resident on VA nights, Tim was admitting a patient from the ED who was reported to have intractable nausea and vomiting due to a gastroparesis flare. Not wanting to anchor on that diagnosis, Tim did a very thorough physical exam and noted the patient had prominent vertical and horizontal nystagmus. Based on this, he was worried about an acute stroke and decided to order an MRI overnight at the VA, which, as our residents know, is no easy task to do. And sure enough, he indeed found the patient had an acute lateral medullary stroke consistent with Wallenberg syndrome. Due to his thorough physical exam, he was able to make that diagnosis, which dramatically changed the course for the patient. It very well could have been missed. So congrats, Tim, and great job. Turn it over to Mita next.
I'm really excited to give the award to Dr. Chirag Kulkarni, who is one of our incredible R3s who consistently shows superb clinical judgment. He was nominated for two distinct clinical decisions. The first was working up a patient on the day of admission for kwashiorkor presentation and hypoproteinemia for a protein-losing enteropathy. He quickly assessed that the protein was not leaving from the kidneys or from the liver and decided to look up a GI etiology, worked closely with consultants, and rapidly diagnosed a rare case of Whipple's disease. His next diagnosis was overnight while he was on the Stanford night team, looking up a patient who had new onset renal failure with multiple other comorbidities with some mild hypercalcemia and very mild anemia, and diagnosing the patient with likely multiple myeloma and sending the appropriate tests overnight that sent her down a different clinical pathway than she would have otherwise been. So I am incredibly honored and proud to present him with one of the 2020-2021 Clinical Decision-Making Awards. Congratulations, Chirag. I'll pass it over to Andrew.
And then last but not least, our final recipient is Jack O'Sullivan. So Jack was nominated for his diagnosis of an elderly patient who presented with a large pleural and pericardial effusion. The initial concern was for underlying malignancy, but Jack maintained a broad differential, lumping possible causes into buckets of infection, malignancy, and rheumatologic/infiltrative disease. And when the data returned less consistent with malignancy, Jack was able to look back and note that the patient had persistently low voltages on ECG, even after the pericardial effusion was drained. It was this small detail and Jack's willingness to maintain a broad differential that eventually led to the team clinching the diagnosis of pericardial amyloidosis, a rare disease that has only been described in the literature a handful of times. So congratulations to Jack, and a final congratulations to all three of our incredible winners. Thank you all so much.
Dr. Moore, as well as Dr. Hoppenfield and Castillo, thank you so much for providing those awards. We have some amazing residents, and thank you for all your leadership this past year as well and being here with us today. So thanks so much. Dr. Pinsky is with us though, and Dr. Pinsky, thanks so much as always for being with us and providing updates.
Thank you, Errol. Good morning, and congratulations to the residents and chiefs. Those were some incredible work that they're doing. Let me share my screen. So I'll give you a brief update on the variants that we have been tracking over the past number of months. So our genomic surveillance has been very consistent over the past 5 weeks or so, with the N501Y containing B117 UK variant being the most common in our patient population, followed by the L452R containing B1.427.429 or California variant. You can see that in green and then in yellow. We did note a slight uptick in the number of cases that contain L452R and investigated that by whole genome sequencing. And it turns out that these were due to a sublineage of the B1617 variant. This is the variant originally identified in India. This 0.2 variant is now the most common in India and is also taking hold in other parts of the world. This is an increase in cases in the UK and some increases in other parts of Europe. So we confirmed 11 cases of this B1617.2 confirmed by whole genome sequencing. This contains the L452R mutation as well as a different spike RBD mutation T478K. So we will continue to monitor this variant in our population. But overall, the number of positive cases is quite low, and things are looking quite positive. So thank you for the time and happy to take any questions about the variants in the chat.
Great. Thank you, Dr. Pinsky, as always, for the updates. Next, I want to turn over to Dr. Dunn. Dr. Dunn has a few updates to share as well.
Thank you so much, Dr. Ozdaga, sorry. Good morning, everyone. I wanted to let you know about a few important events happening this week in the diversity, equity, and inclusion space. There's a lot going on. And first, Medicine and the Muses Stuck at Home concert series is happening tomorrow, May 20th from 5:30 to 7:30 p.m. The first hour is going to be a musical tribute to Asian grandmothers, and that will be followed by a panel discussion on the experiences of generations of Asian women. It's going to feature a group of trailblazing Asian American women. The QR code is on the screen, hopefully. Actually, that's
Sorry, we'll send that out. I don't think I got those slides.
Okay, sorry about that. I think Steph sent that to you. Also happening on Thursday, the 20th from 5 p.m. to 6:30 p.m. will be the Diversity Awards and Networking Spring Reception, which is sponsored by the OFDD. This event celebrates DEI at Stanford Medicine and recognizes DEI champions from the student, trainee, and faculty communities. This year's award winners are pictured here and include our future chief resident, Dr. Christine Santiago. Also, we're pleased to welcome Dr. Augustus White, who was the first African-American graduate from Stanford Medical School, who will be addressing the attendees. Finally, the event will include highlights from the most recent Augustus White awardee, our very own Megan Mahoney, Dr. Megan Mahoney. So this week is packed, so to top it all off, the Office of Diversity and Medical Education is sponsoring the 4th Annual Diversity and Inclusion Forum, which will be held Friday, May 21st from 8 a.m. to 5 p.m. It's going to be a virtual forum that will highlight innovative workshops developed by scholars who are trainees across the GME, along with their educational mentors who are faculty, fellows, and staff across the entire School of Medicine. There will be a keynote address by Diane Chin from the Stanford Center for Racial Justice, as well as a plenary session by Drs. Mitchell Lum and Dr. Juno Obedin-Maliver. Speaking of those two, they will be giving us a grand rounds on the Pride study at the beginning of June, which is Pride Month. And just as a reminder, our next inclusion rounds will be June 17th at noon, and we'll focus on anti-Black racism. Thank you so much.
Thank you so much, Dr. Dunn, and finding all those updates, and to the award winners as well. Congratulations. Next, I just want to briefly mention to end our Asian Pacific Islander Heritage Month, we will be having a focused presentation next week on Native Hawaiian Pacific Islander health. And that's with Dr. Marjorie Leimomi Mala Mao. We're looking forward to that. And as Dr. Dunn mentioned, we have celebrating Pride Month, kicking off Pride Month with Dr. Dunn and Obedin-Maliver. So we're looking forward to that upcoming. But today we are excited again, as I mentioned, to have Dr. Jason Wang. And I've been really excited to hear him speak at Grand Rounds for quite some time, really for a long time, including since the pandemic began. So Dr. Wang, we're so lucky and happy to have you with us this morning. Dr. Wang is an associate professor of pediatrics and medicine via primary care and outcomes research. He is the director of Center for Policy and Outcomes and Prevention. He also co-chairs the Mobile Health and other new technology groups in Stanford for population health sciences. He received his BS from MIT, medical doctorate from Harvard Medical School, and got a PhD in policy analysis from Rand. After completing his pediatric residency at UCSF, he worked in Greater China with McKinsey and Company. In 2000, he was recruited to serve as the project manager for Taiwan's Healthcare Reform Task Force. His current interests have included COVID-19 related policies, developing tools for assessing and improving the value of healthcare, facilitating the use of mobile technology and improving quality of care, supporting competency-based medical education curriculum, and engaging healthcare delivery and payment reforms. Dr. Wang has been extremely busy this past year. I've been seeing his name listed constantly, giving lectures throughout the Stanford community and outside of it. He has been extremely busy as well, making many publications. One example of publication in regards to COVID-19 was an article entitled "The Response to COVID-19 in Taiwan, Big Analytics, New Technology, and Proactive Testing." It was published in JAMA, received over 1 million views online alone. And that's just one example of the many things he's been publishing this past year alone. Dr. Wang is here to talk to us a lot about responses in Taiwan, as well as the opening school reopening. Dr. Wang, thank you so much for being with us. I'm going to stop sharing my slide and allow you to share yours as well. And again, thanks for being with us today. We're looking forward to hearing from you.
Thank you very much, Errol, for your kind introduction. Let me just pull up my slides. Can you see?
Look great.
Okay. So I made a mistake of giving 2 titles. So I guess I have to go through both titles, the subjects in both titles. So we're going to start with the art of COVID command. So actually, running a COVID command center is like being a conductor. Okay. There are some key things to make sure that everything is organized and play the song the way that you want it to play. So the first thing is you got to have a logical mindset. So the logical mindset is evidence-based and scientifically based. And the second thing is that you got to have to play the right sequence. So some things should go before other things would happen. And then the right tempo. Sometimes you have to go fast, and sometimes you could slow down a little bit. And then the last thing is you have to have articulation. So you have to be able to explain things to people in a way that people could understand. And so as you could see from this picture, that there are lots of interdependencies between the different sections of the orchestra. So the first violin, the second violin, they have to know each other's parts. The viola and the cello. So they have to play each other's parts in order to play together. And so this is critically important. So if one person doesn't know the other person's part, then they'll be out of sequence. And one misstep in the pandemic response can revert previous successes. And we have seen this multiple times in the current pandemic, where countries seem to be doing well, and then they had a misstep. And then they ended up with another wave of the pandemic in their country. Despite all the lessons learned, that it is clear that orchestras that play well, and similarly teams that play well, they play together and they practice together. So practicing is actually critically important because all these parts are interdependent, and so you will have a synchronized response. So what is known about, we were sort of halftime now into COVID, perhaps a little bit more, probably in the third quarter. But what is known? So what we know now is that early recognition and decisive action by governments can contain the spread quicker. And part of this is in border control. So maybe with the exception of China, most countries imported their cases initially. And so border control and quarantine is the first step. The second step is you got to allow sufficient time to test and do contact tracing. So having a good border control initial response buys you time. So if you didn't close the borders initially, then you're going to run out of tests and you're going to run out of contact tracing capabilities. And so the numbers that we were looking at was the effective reproduction number, the RT, or initially it's the R naught, but it's really the production number at any given time. And that's the number where the number of people infected by each infected person. So how many people does one person transmit to? And our understanding currently for this virus is about 3 to 4. There are mitigation measures. If you did not contain the virus initially, then you have to mitigate it. So you don't know where you're getting the virus from. So in the United States, that's what happened. That we started with a community spread. We didn't know where the virus is coming from, and so as it spreads, we start to have stay-at-home orders. We close businesses and shops and schools. And what is known now is that these measures begin to become effective in reducing the RT after 10 days of the policy implementation. And so there are other protective health behaviors like washing your hands, masking, and those has been associated, the mask wearing has been associated with a 70% risk reduction. Vaccination is no doubt an important factor in ending the pandemic, and we've been doing quite well with that. And so let's go back a little bit to get into more details about each of the strategies that I mentioned. So command and coordination. Okay. So in Australia, the National Cabinet allows the Prime Minister to have a forum to coordinate with the state premiers and the territory chiefs, ministers. And so together they make decisions together with the help and advice of health and economic experts. And this has allowed them to work sort of in synchrony and convey the message to their population in a consistent and coherent way. The Taiwanese government also activated their Central Epidemic Command Center in January. And this has allowed them basically to work with the local governments and then to take over some production capabilities authorized by the law. So once you activate the command center, the government has special powers. It's like you become a superhero under the special command. And that expires a year from the start of the command. The US health system, as we know, has responded with extreme variation, both between states and within people. And we also happen to be in the middle of an election in 2020. So a lot of the issues were polarized on purpose. And in Brazil, it's very similar. Their president rejected science and downplayed COVID-19, and in fact, fired the health minister. So on the picture on the left, so the president of Taiwan is actually the female president, President Tsai. But the vice president, Chen, happened to be an epidemiologist trained at Johns Hopkins, and he was the head of the School of Public Health and then the former health minister. So when I talked to the president a couple of months ago, and she said the first thing she knew right away was that this was going to be a political issue if she took command. So it is better for the experts, the vice president, to take the podium, and she just needs to stand next to him to support it. So I thought that was very wise for her to decide that right away. And they also had daily briefings headed by the Minister of Health and his advisors that lasted continuously even today. So it usually starts at 2 p.m. local time and it lasts for 1 to 2 hours. So let's look at the response for other countries in terms of border closure and mandatory quarantine and contact tracing. So, countries obviously have different resources, but even for countries with relatively low resources like Nigeria, now if you acted quickly and early enough in a crisis, you're going to have very good outcomes. And so the first confirmed case in Nigeria was actually in February, but in January, they were already convening the multi-sectorial national coronavirus preparedness group. And so what the group did was they released updates on the outbreak and also start to recommend preventive measures. And the land and air borders were closed 30 days after 30 confirmed cases. So after they detected 30 cases, they closed the borders. And they started to quarantine and test people. And then 7 days after border closure, they had a lockdown. And so by the end of May in 2020, they were able to do contact tracing and follow up for 90% of the cases. So if you close the border in quick enough, then you could really follow up each index case and their contacts and trace them. If you didn't, you're going to be overwhelmed, and there's no way you could catch up because it's exponential. It's the 3 to the nth power, and it's the infection cycle is every 3 to 5 days. You could potentially go through another cycle, so you will never catch up unless you have a lockdown, and then even that's difficult. So in South Korea, they had a different strategy, and so they were able to do digital contact tracing, and they used GPS data, which is more invasive because they actually track you exact location. But they also use credit cards data and other sources that's probably not going to be acceptable to us in the United States. One thing that they did was very innovative, where they scale up testing using drive-through testing model, which was 50 times less expensive and 3 times more efficient. And also it saved PPEs because all you need is like the one person doing the sampling. Not everybody gowned up, so it saved the PPEs. The walk-through testing model in urban areas also boosted testing capability. Now, I think everybody is familiar with the Swedish model. They were banking on herd immunity, which was very, very difficult. They did not have any restrictions on border control, and the quarantine was not required. And tests were not available to regular people other than healthcare workers for a while. And by mid-June of last year, their daily cases in Sweden, adjusted for population, was 10 times more than the neighbors, Denmark, Finland, and Norway. So it was some hard lessons learned there. Now, in terms of distribution of resources and PPEs, so Taiwan has ramped up production of the mask from 2.2 million a day to over 20 million a day in 5 weeks. And this was done in March of last year. And I think what is more remarkable is the equitable distribution of these masks using their national health insurance system. And so you bring your national health insurance card to any pharmacy or supermarket, and then they will dispense you 10 masks for every 2 weeks, and it's about 10 cents for each mask. So you pay, a little bit more than $1 to get 10 masks. Now in the UK, even though there were pandemic preparedness and they were supposed to order masks and PPEs, viral equipments, out of the 33 million of the original procurement list of the stockpile, only 12 had been delivered as of April 2020. And so, these sort of pandemic preparedness stockpiles of masks and PPEs, people tend to forget when they get busy. And so, and some of these masks expire too. So you need to constantly be checking as part of the exercise and practice. Now, let's think about mitigation strategy. And so, mitigation, basically, when we ask people to stay home or businesses to close or schools to close, it's because there's community spread and we don't know where it's coming from, and to prevent the surges from overwhelming the health system, to flatten the curve, if you will. We asked people to do that. Now, New Zealand had a lockdown 1 month after its first confirmed case. So they did it relatively quickly, but they prepared for it. So to encourage solidarity prior to the lockdown, they had daily briefings and Facebook live broadcast from the prime minister. And they introduced a 12-week financial subsidy. So, people said, oh, we're going to get subsidy. So that increased the public buy-in. Okay. Now, the Czech Republic has a different twist on the early lockdown. So the government ordered lockdown as early as April. They weren't having a lot of cases, but they ordered the lockdown. Okay. And then for people who were not wearing masks, they were fined. They were disciplined for not wearing masks. And they had all these celebrities leading the movement of like sewing face masks. And this is all great. However, people get tired. There's pandemic fatigue. Okay. So then the citizens start to question, why do we have this lockdown? What there's a conspiracy theory. They think it's a tool for political oppression and control. And so the next time around, when the numbers started to soar in September, even the government didn't want to do another lockdown because it's considered unpopular and it could have a negative impact on regional and Senate elections in October. And so this is a case where, people thought it was crying wolf. Okay. But then when the wolf really came in, then they weren't doing it. They weren't guarding it. And so the cases went up. And so, there are some cardiologists here. So I think the lessons learned is that you have to have systole and diastole. So when you squeeze, you also need to relax the heart before you could pump again. And so you have to give people a break. And so that's probably the lessons learned here. Okay. Now, handling vulnerable populations and spatial populations is always very difficult. And in the case of the elderly, Germany has done a pretty good job. The percentage of infected elderly, 70 plus, was half of Spain and Italy. And the way they did this was the visits to nursing homes were prohibited really early in mid-March. And they didn't reopen until late May, and only specific people could visit nursing homes, like specific relatives. Testing capability was prioritized for older people and care workers in the nursing homes. The recovered residents, if a resident gets COVID, the recovered residents, before they could return to the nursing home, they were required to have a negative test or be quarantined for 14 days. The nursing homes were provided with specific guidance on hygiene measures, how to clean the beds and so forth. And the care workers were paid more. They increased their wages for the care workers and they received a one-time bonus. Now, Canada, on the other hand, had a lot of issues with nursing homes. They accounted for 85% of all reported COVID deaths, compared to the average of about 38% in other OECD countries. The nursing homes tend to be crowded and understaffed, and the ratio is about half of Netherlands and Norway. Many workers were underpaid, and so they work in like 2 or 3 different nursing homes. Now then they start to mix, and so resulted in cross infections across nursing homes. Another very important special population is the migrant workers. And so, Portugal has migrant workers, but they ensure all foreigners applying for immigration status be treated as permanent residents. And they have access to national health service, welfare benefits, bank accounts, etc. Singapore also has a lot of migrant workers. And Singapore initially focused on their residents and did not prioritize or monitor potential risks for foreign migrant workers. But as a result, there was a big disparity between the prevalence rate. So it's like 0.04% in the local population and 16.3% in the migrant workers. And that's because about 300,000 low-wage workers live in high-density and hygienic dormitory settings. They share room up to 20 men and 1 toilet. With up to 180 men. So it's problematic when in crowded conditions and infections will just spread. almost half of the migrant workers were infected, contributing to 94.6% of the total cases as of September 2020. And so, Singapore obviously recognized this was an issue, and they started to aggressively help migrant workers. And the lessons learned there is that we're all in this together. There's not one group that we could ignore. We have to pay attention to every single group. Now, managing uncertainty and variance in reopening. And so Dr. Pinsky just showed us the current prevalence of different strains, and now we have the Indian strain, and I think that's an evolving story. But the first story I want to tell you is gradual reopening needs to be based on data, and that's very important. And so for Finland, school was reopened first as evidence that children may play a smaller role. There's still infection going on in schools, but probably smaller role. They reopened restaurants and public services later when the RT fell to 0.8. So then you need to be tracking the RT, otherwise you wouldn't know it fell to 0.8. So there needs to be a good data system. Now, during the summer of last year, when most Europeans travel across countries in the continent for vacation, the people from Finland decided to stay in Finland, or at most they travel to Norway. So 94% of Finns vacation within their country. They opened a testing facility for arriving passengers in Helsinki. Half of the population in Finland were using the government's contact tracing app with compliance of over 80%. So that allowed a faster response if one were contacts of an index case. They also had good border control. In early September, Finland only has less than 250 cases per 1 million. Only countries with less than 250 cases per 1 million were allowed to travel to Finland. And so in order to know that, they need to be tracking the prevalence of each country and issue visas to travel to Finland. And so because of all these efforts that are data-driven decisions, to protect their public health, by the end of October, the 7-day average of confirmed cases in Finland was 40 times less than Belgium, 8.8 times less than UK, and 4.7 times less than Germany. So the lesson here is that vigilance pays and data-driven decision making pays. So now to end the pandemic, now I think we're in the third quarter of the pandemic. Obviously, vaccines is key. And so developing, securing, and distributing vaccines are key in ending the pandemic. And so one good example is from Israel. So, many countries created advanced purchase agreements with major vaccine manufacturers. And in the United States, we have operations Warp Speed, which we invested in about 1.9 billion vaccines. And I think we assume that 33% of them is going to be successful, and therefore each person will get at least twice the amount of what we need. And so it's a calculation of expected outcome from previous vaccine development efforts, percentages. And then we turned out to be very lucky. We have abundance of vaccines. Now, Israel had also made advanced purchase agreements and received Pfizer's first dose in December of 2020 in exchange for giving them data about the side effects and safety and efficacy when they deploy in Israel quickly. And leverage its population-based childhood web-based immunization registry, and also the semi-private HMOs for both vaccine campaign and follow-up of these adverse effects of vaccination that are expected Vaccine started in December 19, 2020. 48% of the population received the first dose within the first 5 weeks. And so that's a very rapid rollout. So you need to know who your patients are and their qualifications are before you could do a rapid rollout. And I think the issue in our country is that insurance could change every year and they could choose different providers. So within each provider group, we really don't know who the patients are. I received a text message from Mass General Hospital 2 weeks ago telling me to get vaccinated, but I left Boston 10 years ago. So that's part of the story is that we don't know who our patients are. With Pfizer vaccine, you need cold chain preparation, and this is -70 or -80, and that's no small feat. That's very difficult. You have to repackage for easier transportation. So basically, you need to have all that ready. Addressing vaccine hesitancy is one key issue. The officials, health experts, and rabbis work together to dispute false information against vaccination, and they also send volunteers into the neighborhoods to cover up anti-vaccine posters. As of May 8th, 56% of Israel is fully vaccinated. And so they are very close to reaching herd immunity with the vaccinations. Handling surges. So there's obviously and variants, and obviously this is an evolving story. And as variants arise, you need to know how threatening it is. Does that transmit more quickly? Does that evade the immune system? Will people get sicker with the variant? These are all the questions that we have to be thinking all the time. Now, the UK, with this NHS and its efforts to sequence people, for their genomic study, and they also sequenced viruses very quickly. And so the COG UK program was launched in March 23rd in 2020. Initial funding was 27 million when there were only less than 100 cases in the country. So they were thinking ahead in this area. And they've now sequenced 391,000 samples. That's 8.84% of positive cases. The United States, I think, we're very much behind. In the US, we report positive or negative, but the sequencing are done in academic institutions which didn't receive funding until very recently in 2021. And so sequencing help to recognize when viruses mutate and gain transmission advantage. And the lab test for vaccine-generated antibodies are used to test against new variants. And so if you have, for example, AstraZeneca, you generate antibodies with the AstraZeneca vaccine, and then you have a new variant you want to test if that works against the South African or the Indian variant, you could do that. And if it doesn't work, you have to think about adding something to your vaccine repertoire. So, and you could compare the breakthrough infections of those vaccinated versus unvaccinated. Even our best vaccines has about a 90% efficacy against both symptomatic and asymptomatic together. So it's 90%. But if you only look at symptomatic, it's about 95%. The surge testing was done door to door in the UK in areas where new variants were found. So this is an example. Everyone age 11 and older who went through the London boroughs of Lambeth and Wandsworth were asked to take the PCR test for the South African variant when a case was found. So then there were 30 positive cases identified. So they were able to do this very quickly. This is something that they did very well. So I'm going to transition a little bit to health beliefs and culture, because it's not only about strategy. It's not only about conducting the orchestra, make sure everybody plays together. People fundamentally have different beliefs and culture. Okay, so this is a paper we published in JMIR, and the key points here are the individual beliefs, that perceived susceptibility, perceived severity, when, do they believe they're going to get the COVID virus? Do they believe that they're going to get very sick from it? If you're giving people a vaccine, do they really believe they're going to benefit from it? And what barriers do they have? And self-efficacy, do they believe that they could carry out the preventive measures like wearing masks or, wash their hands and keep social distancing or so forth. And then you have the greater government policy, and the government policy is what we talked about before, but individual beliefs are very, very important. So this is a picture of how people wear masks in the East and the West. And so clearly, masks serve a different purpose when you see that. And this is a picture of my daughter when she was 2. This is around SARS 2003. And I taught her to wear a mask because I fundamentally believe that if she's toilet trained, she ought to be able to wear a mask. And I'm a pediatrician. Here's a picture of Patrick Henry in 1775. And this is our country. So we are founded by the idea of liberty. Okay, and the Puritans came to this country for religious freedom. When we explored the Wild West frontier, it's the survivor, persistence, and merging of peoples that made the trip happen. And so there's a lot of cowboy culture. The culture of pioneering we're in Silicon Valley. That's what we're built on, a culture of being pioneering. And so we also have historical burdens. So the Tuskegee syphilis study, which lasted 40 years, is to follow the natural course of syphilis in African-American men. That lasted, let me repeat this, 40 years. So it's very difficult for some of our population to trust the government when we talk about vaccines or masks or any sort of law that seems to be restrictive and handed down. This is what's happening today. New Hampshire, live free or die. This is what happened last year. Again, this is what happened last year. And this is what happened last year. Now, there are other aspects of culture. In some cultures, they have large families that live together in multi-generational households. And so in COVID, it's particularly challenging when you have multi-generation households living together with large numbers. This is another cultural representation, and very quickly that has to change, at least temporarily during the pandemic. And that we've all been handshaking, but that has to change as well. And I go around asking people how they do handshakes. And some people do this, and some people tap their heart. Some people in America, we do the elbow thing. You can do whatever you want, but try not to touch another person when there's potential droplets. Now there's religious gatherings, and this also has changed on how we gather. The lessons learned from culture and psychology is that to build a civil society, you need to account for culture. And you need to balance safety and freedom. You need to balance lives and livelihoods. And these need to be supported by law. And our law lags behind everything that we're doing. People could challenge you in court for almost everything that we ask people to do. They are changing cultural norms during the pandemic, and you have to address the psychological components that are important. You have to use both carrot and stick. Sometimes you have to provide incentives like subsidies, and sometimes you have to do fines, but you have to make it bearable. Okay, so sometimes you have to do systole, and sometimes you have to do diastole. You have to relax a little bit for people to breathe. So there's the temporariness of this thing, this command. A lot of this require public health infrastructure, but you also require social solidarity. You got to believe that we're in this together, and participation of citizenry for both data collection or stopping the spread is absolutely necessary. The government can't possibly do it by itself. Okay. Now I'm going to take a 2-minute, I'm going to breathe for 2 minutes and then maybe 2 seconds, and then we're going to go to school reopening. Okay. So this is an area of major interest to a lot of us, our parents, and we're thinking, well, should we send our kids back to school? And so right now we're sort of in a trial period, right? We're like 5 weeks to get people back to school, and then we're in summer vacation. The American Academy of Pediatrics strongly advocate for return of school in person. And this is for children's education, social, physical, and emotional development and well-being. Okay, but around the world, half of the world's student population is still affected by either full or partial school closures. Okay, however, I think in everybody's mind as a parent, safety is the priority for school reopening, and there's an urgent need to understand the efficacy of safety practices to prevent the the spread of COVID in schools. Right now, the vaccines are authorized for 12 and above, and I think people are working very hard for 6 months to 12. And hopefully before the end of this year, we could give vaccines to every child. But right now, we're not there yet. So, only 12 and above. And so we really need to think about school reopening. So this is the work that we have done in the last 6 months. So between my group and also Bonnie Maldonado's group. So this is a prospective study on school reopening. The objective is to evaluate whether recommended guidelines can limit transmission of COVID within a school environment. And this is before the vaccines were available. Okay, so this was conducted September 2020 to March 2021. Around the end of February, teachers were offered to vaccination. We did this in an independent K-8 school in Menlo Park, and the school partnered with Stanford in the summer of 2020, last summer, to develop a safety protocol based on recommended guidelines from CDC and the California Department of Public Health. And then as part of this, to evaluate the protocol, we conducted SARS-CoV-2 testing weekly among students and staff. Now, to reopen the school actually requires testing, but that requirement is not part of the study. So the school requires it to attend physical school, and we did the evaluation on all these other protocols. So the safety protocol includes fixed cohorts of less than 12. That includes the staff, ventilation, masking, hand hygiene, physical distancing. And in this case, they did AM and PM shifts to effectively reduce the attendance at any given time to half of the student population. We followed daily symptoms, and as I mentioned before, we did a weekly PCR testing, and we developed a school stay-home policy and to shift to distance learning as possible. And then we conducted sort of in-person observations as well to evaluate how this was implemented. So this is the school. They have a lot of outdoor space, and as you could see, that they put desks on the lawn, on the lawn, and also in the parking lot to increase outdoor surfaces. So the things that we ask people daily, the symptoms related to COVID. So you could see the list: fever or chills, cough, etc. The things that we ask people weekly are the exposures, whether they have close contact with a case, they had traveled somewhere, either within California or outside, whether they have been in indoor, outdoor gatherings, and with how many people. We ask them about their health beliefs, perceived susceptibility, and perceived severity. And again, we have weekly testing, and this was done every Thursday. Okay, we test everybody every Thursday, and by Friday afternoon, usually within 24 hours, or sometimes Saturday, we will know the result. And people who tested positive, we ask them not to come to school on Monday, and they have to stay home for 10 to 14 days. We also asked about the vaccination status after vaccines were available to the teachers. And we did monthly observations, walkthroughs on campus, and document adherence to protocols. So this is there were 243 students and staff enrolled, and about you could see the demographics of the staff. They're pretty young, but there were 32% are 40 plus years old. And then the race ethnicity. So this is in Menlo Park, so it's predominantly majority is white, and then 17% Asians, 8% Hispanic, and 2% African Americans, and 10% other or mixed. Same thing, the student population, 42% white, 24% Asian, 3.9% Latino. And so the parent education, most of them were over college. So when we look at the symptoms, so what we found was that of the 19,409 daily symptom surveys collected from September, this is to March, there's a typo. They were less than 1% reported at least having one COVID-19 symptom, less than 1%. Okay, and these are the frequency of the symptoms by students and staff. And so you can see sore throat, runny nose, headaches, nasal congestion, fatigue, cough. They are all the top ones, but overall it's less than 1% of what was reported. Now, if we look at the CDC data on flu-like symptoms in 2021, it's also very low. It's like 1% of visits for influenza-like illnesses, like the bottom one. And that could be because people wearing masks, or they're not going to school, so they're not infecting other people. So that's why it's low overall. What we found 6 positive cases by RT-PCR. All 6 cases, individuals were asymptomatic. They did not report any symptoms at the time of testing, and 4 remain asymptomatic. And they were distributed across 4 households. There were no observed transmission of COVID within cohorts or across cohorts during the 6 months period that we studied this. And then when we look at the perceived susceptibility in 3 time periods, October, January, and March, you can see the middle one, January is the peak of the pandemic. So the staff felt that they were more susceptible, but the parents' response for students did not really increase. And so so there's a statistical difference there in the parents' response to student susceptibility versus the staff feel about whether or not they're going to get the virus. There were 4 on-site observations conducted by study staff during the study period. So there were no intermingling of cohorts. So people stayed within their cohorts. The hand sanitizers was accessible throughout the school. Overall proper mask use was observed and enforced. Now, there were incidences where people didn't really use it properly, and most of it occurred during non-instructional time, like recess. And physical distancing as well was well enforced during class time, but also more difficult during non-instructional time, like recess or drop-off pickup times and transition time and so forth. So what's the implication? So for our study, so our findings concur with other studies within the school environment that this could be minimized with proper mitigation protocols, even when the incidence is high in the community, like in January and February of this year. Now, the reason we believe that is that the infected individuals were on site on Thursday and Friday. So we did the testing on Thursday, and so they were on site Thursday and Friday. They didn't know the results yet, so they were in a cohort in school, but none of the people in the cohorts got infected by these 6 individuals. And then we also found a very small proportion of students and staff reported symptoms, and they're not correlated with the infected individuals. And so we decided we're not going to do that anymore. The utility is low. And plus, people underreport, because, people think it's allergies, and, if they report it, they can't go to school anymore. Because for any people who report symptoms, we tell them to stay home, and then they'll get tested. And so there's a disincentive to report. Currently, we're examining the use of less expensive rapid tests. These are like $5 per pop. as opposed to PCR. It's more expensive. And we're doing the correlation between PCR and rapid test to see if we could do that. And then definitely if they test positive for the rapid test, they have to be followed by a PCR confirmation. So that's it. I think I have 5 minutes left for questions if people have any.
Dr. Wang, thank you so much for that presentation. There's a lot of great information there, and we definitely have questions already popping up. I'll start with Dr. Yen had mentioned this question early on. How would you grade California, the U.S. borders control of and quarantine, contact tracing, isolation measures? Basically, how did we do?
Well, people are handed a different set of issues in the beginning. And so we were handed with community spread, but so it's very difficult to do contact tracing. However, we could have done better. We could have responded earlier last year for sure. And so it's that, proactiveness, being aggressive in the beginning that buys you time to ramp up your testing capability, to ramp up your contact tracing capability. Now, if you're trying to, do this while fighting the pandemic, it's very difficult. And the supply chain issue is a major issue. Countries that try to deal with the pandemic while ramping up their production doesn't work. And even I think I spent quite a bit of time trying to get PPEs for Stanford. And by the time I identify a vendor, their factory are infected and I have to go to another country. So it's like global supply chain management. And so it's very difficult.
Great. Dr. Leibowitz asked, around the time you were presenting the data on Israel, are any countries vaccinating children younger than 12 years old? Could the CDC and FDA use data for our children, I think similar to what the data shared from Israel was? Are you aware of that we might be doing?
Yeah, I think the studies for children under 12 are underway, including those being done at Stanford. And so really the difficulty with children is that it's a different dose. And so you got to figure out the proper dose and so that they don't get a massive immune response. And then it's got to be its efficacy and safety are of primary concern when you give it to kids.
Dr. Siegel asks, what was the prevalence among the parents in your study? It seemed like very low prevalence population, which would be reflected in the kids.
Yeah, the prevalence of it's the prevalence in San Mateo and Santa Clara County during those times. Most people got the virus from the community, right? They probably got it in a grocery store or in a community. And so when they bring it to school, then we detect them and we tell them not to come, even though they hang out with the kids with the cohort for 2 days. But they were practicing all these preventive measures, so nobody caught it. So everybody caught it in the community. And we also have a separate team doing contact tracing, including working with the health department, so we know who got it from who, from the contact tracing, or at least they know, the team that did it know.
Speaking of, Dr. James, I was asking, is there contact tracing happening now, given the low prevalence in California and Santa Clara County? Are you aware?
Yeah, I think the contact tracing is ongoing in the public health department. But more and more, I think we're gonna. So it's too bad that digital contact tracing, digital exposure notification didn't really take off. It took off in the UK, where approximately 50% of the eligible adults and teenagers participated in digital contact tracing. And there was a paper in Nature last week that showed that for every 1% uptick in digital contact tracing, you got 0.8% decrease in cases. And so it's almost a one-to-one relationship. And they did it in the UK. So they've been successful with that.
Dr. Wang, we're just hitting 9 o'clock right now. I think we'll close, but I do want to thank you again for everything you've been doing this past year since the pandemic began. Thank you so much for being with us today. And I want to wish everybody else who joined us, thank you as well. Thanks again to our winners of the awards and our residents. And I hope everybody has a great rest of the day and week.